I'm Nick Ferran. I'm a consultant trauma and orthopedic surgeon specializing in shoulder and elbow surgery. I'm passionate about delivering awake shoulder and elbow surgery under regional anesthesia where appropriate, and have interests in treating conditions such as frozen shoulder, rotator cuff tears, fractures and dislocations around the clavicle, shoulder, and elbow, and nerve problems such as cubital tunnel syndrome and carpal tunnel syndrome. If you have any of these problems or want a consultation about your shoulder or elbow, please get in touch with our practice management team. Carpal tunnel syndrome is a condition where the median nerve is compressed in the carpal tunnel in the wrist. Most of the time this doesn't have a specific cause, but sometimes it can be caused from repetitive jobs such as computer work, can be caused from abnormal sleeping positions with the wrists bent at night, can be exacerbated by patients during pregnancy, or with some medical conditions such as rheumatoid arthritis or some other endocrine conditions can also trigger symptoms. With carpal tunnel syndrome, patients most commonly complain of pins and needles in the thumb, index, and middle finger of the hand. They sometimes can experience shooting pain from the wrist to the fingertips, or shooting pain from the wrist up the forearm. The pins and needles most commonly occur at night, and often patients are woken up by the numbness in their hand and have to shake their hands or hang them out the side of the bed to get the symptoms to improve. The symptoms can sometimes occur in the day as well, and most of the time they're intermittent. But if the condition is left long enough without treatment, it can progress to have permanent pins and needles or numbness in the fingers, and also muscle wasting in the hand, which can cause weakness of grip, leading to patients dropping items. The treatment for carpal tunnel syndrome depends on its severity and how long the patient has had the condition. So initially, in mild cases, patients are advised to wear night splints or alter the ergonomics of their workstations to try to improve symptoms. In more severe cases, where the patient has not responded to splinting or can't change their work activities, and the symptoms are becoming intrusive, a steroid injection to the carpal tunnel might be done by your GP. If this does not help, or if the symptoms are severe and there is muscle wasting in the hand causing the patient to drop things, then surgical release is recommended. And this is done under local anesthetic with a small operation to release the nerve as it passes through the carpal tunnel. This is often done as a day case procedure. The patients are encouraged to use the hand straight away. I take the bandages off my patients 24 hours after the surgery, and we remove the stitches at about 2 weeks. The patient gets back to activity quite quickly. Most carpal tunnel operations are done under local anesthetic as a day case operation, and I recommend that my patients start using their hands straight away. The bandages are removed after 24 hours, and that allows further hand and wrist function. The patient will feel as though they've cut their hand, and that may limit some activity for the first few days, but usually that pain settles quite quickly and they can get back to activity. A common feature after carpal tunnel surgery is pain across the base of the hand. And patients notice this when they push up. And this can happen or last for several months and is normal, but will settle down. Most carpal tunnel surgery is done under local anesthetic as a day case operation, and I recommend that my patients start using their hands as soon as possible. The bandage is removed the day after surgery, and that allows more hand and wrist function. The dressing must stay on until the sutures are removed at about 2 weeks, and it's important to keep these clean and dry. So showering can start straight away the day after surgery, as long as the hand can be wrapped in something like cling film or a plastic bag to keep the wound dry. We recommend early return to function in terms of daily activity, such as dressing yourself and cooking, because using the hand early on is really important for the recovery. Return to sport should probably be limited until after the sutures are removed, so that we are sure that the wound is fully healed. Definitely return to driving should be after any bandages or dressings are removed and the patient's comfortable enough to grip a steering wheel without hesitation. Otherwise, they may be dangerous to themselves or other drivers on the road. Most patients can return to work quite quickly, and if you're in a computer-based job that can keep the hand clean and dry, you can return to work potentially the day after surgery and start using a keyboard straight away, as this is good for the rehabilitation.